You're 68 years old. You feel fine. Maybe a little tired, but you chalk that up to getting older. You've been on your blood pressure medication for 6, maybe 7 years. Every checkup, your doctor glances at the chart, nods, says your numbers look good, and sends you home. You trust him. You have no reason not to. But here's what nobody told you. Every year, over 200,000 older Americans are hospitalized, not because of their high blood pressure, but because of the medications they were given to treat it. Falls, kidney damage, dangerous drops in blood pressure, heart arrhythmias, cognitive decline. These aren't rare side effects buried in a footnote. They are happening at scale, in people exactly like you, and they are being systematically under-discussed. Amlodipine, Losartan, Lisinopril. These are among the most prescribed drugs in the world. Millions of seniors take them every single morning with a glass of water and never think twice. I'm not here to tell you to throw them in the trash. I'm here to tell you something far more important. These drugs work differently in a 70-year-old body than they do in a 50-year-old body, and the dosing conversations that should be happening in your doctor's office, in far too many cases, aren't happening at all. By the end of this video, you will know exactly what questions to ask, what warning signs to watch for, and what the evidence actually says about blood pressure targets for seniors. What I'm about to share is something a lot of physicians won't cover in a 15-minute appointment because there's never enough time, and frankly, because most assume you won't ask. You're asking now. So let's get into it. My name is Dr. Everett Cole. This channel exists for one reason: to give adults like you the information the medical system assumes you either don't want or can't handle. What I share comes from years of studying medical literature and watching what actually happens when the system runs without asking the right questions. Nothing here is a substitute for your own physician, but knowledge is the foundation of every good medical conversation. So let's build some. The aging pressure paradox. Here's the framework I want you to hold in your mind for everything that follows. For decades, medicine treated high blood pressure the same way across all ages. Find it, lower it, keep it down. The assumption was simple: lower is better. Always. And in a 45-year-old man with a racing heart and a stressful job, that logic largely holds. But the aging body is not a younger body with more wrinkles. Think of your blood vessels like a garden hose that has been outside for 30 years. The rubber has stiffened. The walls have thickened. The hose no longer flexes the way it once did. When you squeeze one end of a stiff old hose very hard, which is what aggressive blood pressure lowering essentially does, you don't just slow the water. You risk cutting it off altogether to the parts of the garden that need it most: the brain, the kidneys, the heart. This is the aging pressure paradox. The same medication, at the same dose, with the same target number, can protect a 50-year-old and quietly harm a 75-year-old. Your arteries after 65 are not just older versions of what they were. They have fundamentally different hemodynamic needs. And the medications designed to manage those arteries, Amlodipine, Losartan, Lisinopril, were tested primarily in populations that did not look like most of the people now taking them. Keep that image of the stiffened hose in your mind as we go through each point. It's going to explain a lot. Point 1. The fall no one warned you about. Amlodipine, one of the most widely prescribed blood pressure medications in the world, is directly linked to falls in older adults, and the mechanism is so well understood that it borders on inexcusable not to discuss it at every prescription renewal. Margaret was 71, a retired elementary school librarian from Raleigh, North Carolina, sharp, active, and proud of the fact that she still did water aerobics 3 mornings a week. She had been on amlodipine 10 milligrams for 4 years when her daughter called me, not for a checkup, but because Margaret had fallen twice in a single month, once getting out of bed, once rising from a chair in her living room. Both times, she said the room felt like it tilted. Her doctor had attributed it to inner ear issues and referred her to an ENT. The ENT found nothing. What nobody had checked was her standing blood pressure, because her sitting blood pressure was controlled. When we finally measured it lying down, sitting, then standing, her pressure dropped 28 points within 60 seconds of standing up, a textbook case of orthostatic hypotension, caused not by her ears, but by her medication. Amlodipine belongs to a class called calcium channel blockers. It works by relaxing the walls of your blood vessels, which is exactly what it's supposed to do. In a younger, more elastic vascular system, when you stand up, your body compensates quickly, squeezing peripheral vessels to maintain pressure to the brain. That response, called the baroreflex, slows with age. Add a powerful vessel-relaxing drug to an already sluggish baroreflex, and you get what's called orthostatic hypotension, a significant drop in blood pressure upon standing. A 2019 analysis published in JAMA Internal Medicine found that older adults on calcium channel blockers had a 31% higher risk of serious fall-related injury compared to those on other antihypertensive classes. 31%. That's not a footnote. That's a frontline clinical concern. What to do instead? Ask your doctor to perform an orthostatic blood pressure check at your next visit, lying down, sitting, and standing, 60 seconds apart. If your pressure drops more than 20 points systolic upon standing, that is clinically significant and worth addressing. Dose timing adjustments, hydration strategies, and in some cases, switching medication classes can dramatically reduce this risk. You should also rise slowly from chairs and beds, pause at the edge for 30 seconds before standing. And if yours dismisses this, that itself is important information. Point 2. What Losartan is quietly doing to your kidneys. Losartan is prescribed to protect your kidneys. For many patients, particularly diabetics, it does exactly that. But in older adults with pre-existing kidney impairment, which includes roughly half of Americans over 70, it can accelerate the very damage it was designed to prevent. This contradiction is almost never explained at the pharmacy counter. Robert was 74. A weekend fisherman and retired auto mechanic from outside Birmingham, Alabama. He'd been on Losartan 100 milligrams for type 2 diabetes management for 3 years, when routine blood work showed his creatinine, a key marker of kidney function, had crept up noticeably. His doctor noted it as mildly elevated, but kept him on the same regimen. 18 months later, Robert's GFR, his kidney filtration rate, had dropped below 30. He was now in stage 4 chronic kidney disease, being referred to a nephrologist for dialysis planning. Nobody had connected the progression to the medication that was supposed to be protecting his kidneys. The drug was doing its job, but the dose had never been reevaluated as his kidney function declined. Losartan works by blocking a hormone system, the renin-angiotensin-aldosterone system, that regulates both blood pressure and kidney filtration. In early chronic kidney disease, this is often protective, but as kidney function declines, the same blockade can reduce filtration pressure to dangerously low levels. The kidneys are like a filtration plant with pressure-dependent pumps. Losartan lowers the pressure in those pumps. In a well-functioning plant, that's fine, efficient even. But in aging equipment already running below capacity, lower pressure means slower filtration, accumulating waste, and progressive damage. A landmark trial from the National Kidney Foundation, the Renal trial, demonstrated this dose-dependent relationship clearly, yet real-world monitoring of kidney function in seniors on ARBs remains inconsistent. The United States Preventive Services Task Force recommends regular creatinine and GFR monitoring for any patient on Losartan over 65. Many practices don't run it annually. What to do instead? Ask your doctor. When was my last GFR and creatinine checked, and how do my results compare to a year ago? If you've been on Losartan for more than 2 years without a year-over-year kidney function comparison, request one. If your GFR has trended downward, dose reduction or substitution may significantly slow the decline. Don't wait for symptoms kidneys don't hurt until the damage is severe. Point 3. The lisinopril cough that becomes something worse. Lisinopril is one of the most prescribed drugs in America, and it has a well-known side effect, a persistent dry cough that most patients, and even some doctors, treat as a minor inconvenience. What it actually is, in older adults especially, is a warning signal with serious secondary consequences that are almost never discussed. Dorothy was 77, a grandmother who still kept a garden in suburban Columbus, Ohio. She developed a cough about 8 months after starting lisinopril. Nothing dramatic, just a persistent tickle in her throat she couldn't quite shake. Her primary care doctor attributed it to allergies. She saw an allergist. She saw a pulmonologist. She had 2 chest x-rays. What nobody connected for nearly 14 months was that the cough was classic ACE inhibitor-induced cough, and the months of coughing, combined with her age and mild osteopenia, had caused her to fracture 2 ribs from the repetitive strain. She'd also avoided social engagements for months because of embarrassment. The psychological toll was significant. The fix, once identified, was simple: switching to an ARB. The cough resolved in weeks. The rib fractures took considerably longer. Lisinopril belongs to a class called ACE inhibitors, angiotensin-converting enzyme inhibitors. One of the byproducts of this enzyme-blocking process is an accumulation of a substance called bradykinin in the lungs. Bradykinin irritates airway receptors, producing a characteristic dry, non-productive cough. It affects anywhere from 10 to 35% of patients, with higher rates in women and in Asian populations, and it never goes away while the drug is being taken. The under-recognized danger isn't the cough itself, it's what the cough does. In an older adult with already reduced bone density, chronic, forceful coughing generates significant thoracic pressure. A 2021 retrospective cohort study published in the British Journal of Clinical Pharmacology found that patients with ACE inhibitor-induced cough had a measurably higher rate of rib and vertebral stress injuries than matched patients on other antihypertensives. It also found significant rates of undiagnosed depression and social withdrawal linked to the symptom. What to do instead? If you have a cough and you are on lisinopril, tell your doctor, "I'd like to know whether this cough could be ACE inhibitor related and whether switching to an ARB is appropriate for me." ARBs, like Losartan, achieve nearly identical blood pressure control without the bradykinin buildup. The transition is routine. The persistence of this symptom is not inevitable. You do not have to live with it. Before we get to the final 2, I want to ask you something. Has a medication side effect ever taken months or longer to get properly identified? Maybe it was yours, maybe it was a parent's. Drop it in the comments below. Your experience might be exactly what someone else watching this needs to hear before it's too late. I read every single comment in this community. Point 4. The blood pressure number that is actually too low. There is a growing and deeply important body of evidence suggesting that for adults over 75, aggressively pushing blood pressure below 120 systolic, which is the target many physicians still work toward, may increase the risk of death, cognitive decline, and kidney failure. The number that was supposed to save your life may, at a certain age, become the number that shortens it. William was 80. A retired civil engineer from Portland, Oregon, who could still solve differential equations in his head. He came to my attention after his daughter, a nurse, noticed he was becoming increasingly foggy and disoriented over several months. His primary care physician had recently optimized his regimen, adding a third antihypertensive to achieve a systolic reading consistently in the 115 to 118 range. The doctor was proud of the number. William could no longer reliably remember his grandchildren's names. When we reduced his medication burden and allowed his systolic to rise to the 135 to 140 range, which most guidelines still label elevated, his cognitive clarity returned over 8 weeks. The medications had been cutting blood flow to an already aging brain. The ideal number had become a clinical error. Here is a physiological truth that the standard blood pressure guidelines have been slow to integrate. As we age, our cerebral autoregulation, the brain's ability to maintain stable blood flow across a range of pressures, shifts. A younger brain maintains consistent perfusion even when systemic pressure drops. An older brain, particularly one with early small vessel disease, depends on a higher baseline pressure to maintain adequate flow. The landmark SPRINT trial, which drove much of the push toward lower blood pressure targets, showed cardiovascular benefits from aggressive treatment. But the ACCORD trial and subsequent subgroup analyses showed that in older adults and those with certain comorbidities, the same aggressive targets led to more adverse events, not fewer. A comprehensive review published in the Journal of the American Geriatric Society in 2020 concluded that for adults over 80, blood pressure targets above 130 to 140 systolic may reduce all-cause mortality compared to tighter control. The medical community is still catching up to this data. What to do instead? Ask your doctor directly. Given my age, what blood pressure target is appropriate for me, and what evidence supports that target? If you are over 75 and being pushed toward a systolic below 120, ask whether the SPRINT subgroup data for older adults has been considered. If you've noticed increased fatigue, dizziness, or any cognitive changes after a medication adjustment, report them immediately and request a review. Any good physician will welcome these questions. Point 5. The drug interaction your pharmacist might have missed. Blood pressure medications don't exist in a vacuum. They are, for most seniors, one layer in a complex pharmaceutical stack, and the interactions between antihypertensives and the other medications older adults commonly take create risks that are poorly tracked, poorly communicated, and dangerously common. Eleanor was 73, a former school teacher from Savannah, Georgia, who was meticulous about her health. She was on Amlodipine for blood pressure, atorvastatin for cholesterol, and had recently started a low-dose NSAID ibuprofen for hip arthritis. Her doctor knew about all three. What no one had calculated was their combined effect. NSAIDs like ibuprofen blunt the effectiveness of virtually all antihypertensives by causing sodium and water retention. Eleanor's blood pressure, previously controlled, began running 158/92. Her doctor, seeing elevated numbers, increased her amlodipine. The ibuprofen negated much of the increase. Her pressure stayed up. The dose kept climbing. By the time her pharmacist flagged the interaction, she was on a higher dose than she needed, experiencing significant ankle swelling, and had developed early signs of medication-induced fluid overload. The solution was not a higher dose of anything. It was stopping the ibuprofen. NSAIDs inhibit prostaglandin synthesis in the kidney, which causes sodium and water retention. This directly counteracts the mechanism of most antihypertensives, particularly ACE inhibitors and ARBs, but also calcium channel blockers. The American Heart Association has issued guidance on this interaction, estimating that regular NSAID use raises systolic blood pressure by an average of 5 points, enough to appear as uncontrolled hypertension, and trigger medication increases that are, in fact, unnecessary. Beyond NSAIDs, other common culprits include decongestants, pseudoephedrine, certain antidepressants, and even licorice-containing products. A 2022 analysis from the American College of Cardiology found that nearly 1 in 5 older adults on antihypertensive regimens had at least one active drug-drug interaction that could meaningfully affect blood pressure control, and fewer than a third of these had been flagged by the prescribing physician. What to do instead? At your next appointment, bring every medication and supplement you take, including OTC drugs and vitamins, and ask specifically, are any of these interacting with my blood pressure medication? If you take ibuprofen, naproxen, or any NSAID regularly, discuss alternatives like acetaminophen for pain management. A pharmacist-led medication review, something called a brown bag review, can often catch interactions a busy primary care appointment misses. Ask for one. Before your next blood pressure medication review, write these down. Bring them to your appointment. You are entitled to complete answers. 1. The fall question. Has anyone checked my blood pressure lying down, sitting, and standing? I want to know if I'm experiencing orthostatic hypotension. 2. The kidney question. Can we look at my GFR and creatinine trend over the past 2 years? I want to understand if my kidney function is stable, improving, or declining. 3. The target question. Given my age and health history, what blood pressure target are we aiming for? And is that target based on current evidence for adults my age specifically? 4. The interaction question. Are any of my other medications, including OTC drugs, affecting how my blood pressure medication works? 5. The reassessment question. When was my blood pressure regimen last formally reviewed? Not just my numbers, but my full medication list, my dose, and whether I still need everything I'm taking. Any good physician will welcome these questions, and if yours dismisses them, that itself is important information. There is a version of medicine that treats blood pressure as a number on a chart, a target to hit, a box to check, a liability to manage. And then there is a version of medicine that treats you as a person. With a brain you want to keep sharp, legs you want to keep steady, kidneys you want to carry into your 80s without a dialysis chair. After 65, the goal of your blood pressure management should not be to achieve the most aggressive number. It should be to achieve the number that protects your quality of life, your independence, your ability to get out of bed without the room tilting, your ability to remember your grandchildren's names. Those are not soft goals. Those are the only goals that matter. Medicine has powerful tools for getting there. Amlodipine, Losartan, and Lisinopril have genuinely saved lives. This video is not an indictment of those drugs. It is a demand, a respectful, evidence-based demand that the people prescribing them think carefully about the bodies receiving them, and that you, as the person in that body, feel empowered to be part of that conversation. You have the right to know what your blood pressure target is and why. You have the right to know what side effects your medications can cause, not the fine print version, but the honest, plain language version. You have the right to ask whether a medication adjustment is based on your age-specific data or on population averages that may not reflect your biology. You have the right to request a full medication review. You have the right to a second opinion. These are not the rights of a difficult patient. They are the rights of an adult human being who trusts the medical system enough to engage with it, and who deserves that trust to be returned. I want to ask you something personal before you leave. Has a blood pressure medication or any long-term medication ever caused a side effect that took months to identify? How did it finally get caught? Share it in the comments below. Your story might be the thing that finally gets someone else to ask the right question before real harm is done. I read every single comment in this community. If this video gave you a new way of thinking about your blood pressure medication, subscribe. I put out videos like this every week. Practical, evidence-based, and honest. Not pharmaceutical-friendly. Not designed to reassure you into complacency. Designed to give you exactly what you deserve. Health information that treats you like the adult you are. I'll see you in the next one.